All right, good afternoon, everybody. We'll let people trickle in, but we'll at least go ahead and get started. Thank you so much for coming this afternoon. My name is Anjali Joshi. I'm going to be moderating the panel today on behalf of the National Council here. And we picked a good one, something I'm sure we all deal with every day around improving relationships between payers and providers, but also some of the misconceptions that come alongside that relationship. Would you all like to introduce yourselves before we get started?
Absolutely, thanks. I'm Jonathan Seltzer, CEO at Simple Practice. We're a practice management and EHR serving more than 200,000 solo and small group mental health professionals.
Good afternoon, Manny Ariso. I'm the Chief Network Officer for Carillon Behavioral Health, as well as the President of their Employer Division.
Hi, I'm Ellen Holsworth. I'm the Director of the Bradley Reach Virtual PHP Program at Bradley Hospital, which is part of the Brown University Health System in Rhode Island.
Hi, I'm Sarah Fleury. I'm the Managing Director of Behavioral Health at Blue Cross and Blue Shield of Rhode Island.
And I'm Dana Lipton. I'm an LCSW in private practice and formerly at Optum.
All right. If you have any questions throughout the panel for these folks, there's a QR code up there that will pull up a Slido page, and you can ask it there. Or if you can't get that to work, we can use the microphones towards the end. Dana, I'm going to start with you on the end there. We've talked a lot about payer-provider relationships, how fraught they can be, but also the misconceptions that come with us. You've also sat on both sides of that table, so we'd love to have you kick it off of what are your thoughts around the relationship, the misconceptions of those relationships as well?
Yeah, so there's so many assumptions, right, that I think people are making, but it's important to remember that, right, they are assumptions that are often passed down from provider to provider, and they are circling through payer organizations, right, just stories with a real negativity bias, I would say, too, right? One bad experience seems to color the whole thing for everybody. With that said, I think there are some buckets. I don't think I'm saying anything new that nobody's ever thought of, right? But I think payers tend to think providers aren't necessarily thinking about quality, or they're gaming the system, and then providers are out there assuming payers don't want to pay them, or that they're intentionally making things hard. But I think that is also coming from a fundamental misunderstanding of each other's business models, right? Like your average provider has not seen the complexity that is the inside of a payer organization, and a lot of folks in payers payers have not run a small business and seen all the challenges there.
So Jonathan, on the complexity side, I was in the exhibit hall today. The solutions on the technology side just continue to explode, right? Measurement-based care, AI, all sorts of things. From a simple practice perspective, what do you think the role is of the EHR when it comes to all these solutions, and how does that play in with how you straddle between payers and providers as well?
It's a good question, and I think it's certainly been changing quickly as we think about when EHRs even came into existence, and that whole purpose today is still really to be the system of record for electronic health records. And as call it data becomes more prolific, cheaper to access and use, I think the landscape for EHRs is increasing or changing quite quickly. But I guess we see it from the standpoint of both electronic health record, but then also practice management / business management. And what I think is an opportunity is for EHRs to be open with how they're sharing their data, and we're seeing this happen real time in some pretty big headline use cases, but be a system that allows that patient record to easily transfer and allow the rest of the market to continue to innovate around that, because no one system should necessarily be the gatekeeper to that data.
How do you balance that with providers? Typically, first question anytime they want a new technology is, does it integrate with my EHR? And kind of being that technology Venn diagram at least.
Yeah, it's not easy, because there is a real cost to being able to integrate and then support multiple integrations. Simple Practice today has very few, and part of that is by design. The segment of the market that we're serving is solo and small group, and so our customers come to us, and it's in our name. It's simple, it's intuitive, it's all-encompassing, and so we kind of look at it through the lens is that, where are we at in a certain adoption curve? Like when we had embedded telehealth before COVID, and only 6-8% of our providers were utilizing the telehealth functionality. Now today, it's virtually everyone. And so I think it's really looking at what are our customers demanding, and then what aspects and how prolific across a given customer base.
Thank you. So there's a budding partnership here of, I would say, you guys are trying to come at it from another angle of how do you actually have payers and providers work together. Talk to us a little bit about how did this start? What were the intentions behind it? What are some of the success you've seen in bridging that gap? And what are still some of the challenges that take more time to kind of work themselves through?
Sure, I can start, and then Ellen, you can jump in. So our partnership, we've had a long-standing partnership. Bradley is a really trusted provider in Rhode Island. They're the lead children's behavioral health hospital, and they just do a lot of great work. And I would say our relationship really started growing in 2018 when Blue Cross and Blue Shield of Rhode Island stopped doing any prior authorization and concurrent review for in-network behavioral health services. So we've discontinued all of that, and what that's allowed for us is to really engage with our partners, because they're not spending that time and those resources doing anymore. They have more time to talk about quality metrics and talk about things that they want to grow within their system. And so we've really spent a lot of time with Bradley thinking thoughtfully about how do we build this continuum of care so that less kids are needing inpatient, and let's help you grow your outpatient business. And so I don't know if you want to talk a little bit about some of the particular things we've done.
Yeah, so I would say that removing the requirement for prior auth has really created a foundation of trust that's meant we can, like you say, it's meant we can innovate together and think creatively outside of traditional fee-for-service funding. So some of the things we're doing are our Center for Autism and Developmental Disabilities is training up community providers to adapt CBT and DBT interventions for neurodiverse populations. And you are paying the community providers a stipend for attending those courses, which is, I think, an example of how we're thinking creatively. We're thinking outside of the hospital, and we're thinking about how we can actually build a system of care in the state as a whole, which is really exciting.
Yeah, and one of the things that Bradley does so well is recognize that they can't be the only provider of children's behavioral health in the state. And so one of the problems they brought to us was like, we have more referrals than we can get, but we don't know who to refer people to that are performing really giving high quality services. And so that training program is a great example of the way we partnered to have those Bradley clinicians use their skills to help build up our network. And we're doing that in anxiety disorders as well. And then next year we'll be doing a training for substance use disorders for youth.
That's great. I'm glad you guys brought up quality and measurement, because that inevitably comes up. And I'll open this up to all of you here, but tell me a little bit about how that's actually working in practice across all of you. So we talk a lot about quality, the differing definitions of quality, how you even measure it. But there's a lot around measurement as well, right? What payers would like providers to measure, what providers think is helpful to measure, the burden we hear a lot that actually comes with measuring and even using it. So would love to hear from as many of your perspectives as possible. How are you kind of bringing those together, or at least trying to make progress on what some of the thinking is around quality and measurement when you have such different folks at the table that have different needs and uses for some of these measures and measurements?
I can start, at least not from a clinical perspective, but what we're trying to build for clinicians, which is really take away the administrative burden, because our providers, practitioners, physicians, they absolutely care about quality. What's really hard is when it's sort of an added step in the workflow, both for themselves, but then also their clients and patients. And so we're looking to just continue to expand, call it the measure library, but then more importantly, automate scoring, automate reminders, call it in and out of sessions, and then really work with other partners on developing what a baseline might look like, so that we can continue to make improvements. And then beyond the measure side is that there's a lot of qualitative inputs in terms of individuals' well-being that both, is outside of some of the historical scoring that we're looking to incorporate both from a client perspective, but then also, obviously in mental and behavioral health, the provider has a unique perspective of, call it life skills, and that, only a provider can see improvement from their side that can be incorporated into, what we deem as quality.
So I would say from our view as a large payer, really thinking about what is happening within the network and then aligning the incentives appropriately and ensuring that at the end of the day, we're all on the same page of wanting quality access to care. And so, and then how does that translate at scale when you're talking about a network of over 200,000 providers? And so within that, a lot of single shingle sole practitioners, small and large groups, facilities, all different levels of sophistication, but all doing really good and important work. So then how do we align at scale, right, around partnering and solutioning so that those folks on the ground doing really good work that might be a sole practitioner, that might be bending the cost curve from a total cost of care perspective, actually get rewarded in a way that makes sense, that isn't just about the primary care setting or around the large health system setting or around a facility-based setting, but really being more deliberate to say, how do we group, how do we scale, and how do we do things for one that we could do for many. So that's the view that we're taking, and also taking a view of really thinking through not managed care, but measured care, right? So, I think as we think about the days of managed care, and from my personal view, is a yesteryear kind of a dynamic, and we really should be focusing on measured care. And so then what do we measure, right? We should be measuring things that matter and that count. That doesn't mean that from a health plan or payer perspective, National Quality Forum and HEDIS and all those things go out the wayside. But what matters most for that patient, for that member that's experiencing care, right? Immediate access, therapeutic alignment, actually getting better, progressing, on whatever standardization. So the things that we're looking at is, what are you using at scale? What are providers using at scale and using those metrics to measure versus being so rigid to say, well, things that we get paid for and that we care about are, 7 and 30-day follow-ups. And we care about, emergency room use and what's happening after that. All things are very important. I'm not dismissing those things, but the member experience is equally as important, and especially with what's happened coming out of COVID, where it's okay not to be okay. Now what? And I think now that's really the opportunity as we think about quality and measurement that we really need to be pushing on, and all collectively as an industry leaning on, so that we do receive and achieve the same goals that we all have, which is have quality access to care.
I would say, I think here there's a consensus that measurement matters. I think that's not from a perspective of a large health system. I think that's not true in a lot of organizations. And I think it's hard. It's really, really hard in large health systems. But I think there is an evidence base that the act of measuring improves patients and means they get better faster. I think that's something we have to socialize. That is something we could be doing for our patients that we're not doing consistently. And hopefully that creates buy-in over time.
Yeah, I'll just add on to what Manny said. In Rhode Island, we have an interesting additional layer of bureaucracy in measurement-based care. We have an Office of the Health Insurance Commissioner, and each year they put together a measure set that payers are allowed to use in their contracts. And so payers and providers all get in a room and they agree on these measure sets that we'll use for a variety of topics: behavioral health, primary care, ACOs. And it gets difficult because at the end of the day, when you get everyone's interests, all coming together in one room, all it seems we can agree on is things that people can easily measure. And so for a health plan, we can easily measure HEDIS measures, right? And so we have the infrastructure to measure that. But for an outpatient behavioral health provider, a 7 or 30-day HEDIS measure when you're a solo practitioner means nothing. You may have one person in a year go to the hospital. So we can't build any incentives into your contract if you're going to have one person go to the hospital. So it's hard, and I think, you know, we need to think about the tools that providers are using and how can we support them as a payer to, you know, have things that measure, and that maybe, you know, maybe they're not incentivized on them because of the rules we have and we're not allowed to do it, but maybe it helps us figure out who to best refer people to. Maybe it helps us with provider matching when we know our members are looking for certain providers. So it's hard, and no one's got it figured out.
They're working so hard on it, I know. Yeah, the member provider matching, I think, is such a huge value prop with measurement. But right, from the clinician perspective, right, as a social worker, I wasn't taught measurement in school, and I think a lot of clinicians probably relate to that. And we don't think it's not good, right? I think we all agree it's good, but there's a lot of clumsiness, I think, in how to implement it, which is a big barrier. And I also think we need to start thinking about it as a value add, and because it's good clinically, and less on the burden part, right? If this becomes how we deliver care, then it's not a burden anymore.
Manny, kind of a follow-up, but a little bit of a non sequitur question for you. So measurement, incentives, inevitably between payers and providers, reimbursement and payment models always come up. The challenges for the providers of wanting more reimbursement to be reimbursed for specific things, the challenges on the payer side of managing the utilization, the budget, and everything that comes with it. How are you thinking about the progression around alternative payment models, knowing that so far a lot of what we have really is not moving the marker? A lot of it is also driven around we're not necessarily measuring the right things that even move the marker. So what are some different ways that you're thinking about breaking out of that current mold, especially to the point you were speaking on earlier of measure and not just measurement?
So it goes back to what I said around aligning incentives. And also, to be perfectly frank, we have a very dated way of paying in general, right? Starting off with an underlying payment methodology that is probably flawed, right, from a fee-for-service perspective. And so in many ways, you really have to start with, because most APMs or value-based payment arrangements start with the basis of like, this is my rate, right, or this is the fee-for-service schedule based off of CMS or some state-specific schedule. And so it's really starting off like, is that the right way to do it? Let's start there. Like, should that be the jumping off point? Oftentimes, especially when you get actuaries in a room, you start doing the financial mechanics around it, the question will come, if we don't start there, where do we start, right? But I think it really goes to the baseline of where do we start and how do we align incentives so that those could do the good work. But the other part of it is we also have to create a system that allows for winners and losers. Right? And that's sometimes I even pause before I said that, right? Because you've never met a bad provider, right? And so, but there has to be an opportunity at scale to actually have winners and losers, and nobody wants to be on the losing end side of that. And then I'm not talking about putting dollars at risk, but we have, you know, when we think about healthcare affordability, there's a finite amount of dollars and resources. Right? And so the majority of the transactions we do, you know, at Carolina Behavioral, is not our dollars. They're our customers' dollars. They're the state's dollars, or they're federal government's dollars. They're not our dollars. So it's not like, you know, you know, I'm daddy, you know, daddy Warbucks, I'm swimming in a pool of dollars, right? I'm actually transacting with the basis of affordability on behalf of others. And so, and we want it to work. We don't, you know, we want it to work seamlessly, we want it to work effectively, and we want it to work very timely from a payment perspective. But in order to actually get to true incentives, I think we have to start at the baseline of, are we starting from the right place? And could we at scale, not individual contracts and hand-to-hand combat, right, but at scale, can create systems that allow for, within, you know, relatively winners and losers based off of outcomes.
What do you think the payer's role is when it comes to the losers, quote unquote, in the network? Or what would you want it to be?
To make them not be losers. So
Well, yes, how?
that's an easy one. No, comparatively speaking, right? So this is also about comparison. When I say losers, I don't mean that they're not doing good work, right? But you start thinking about comparatives and doing it the right way, right? And I've heard it 1,000 times. Well, but they have easier patients than I have. Or they, are you risk rating things? How are these things aligning? I have all the hard ones. They have all the easy ones. Is it fair? Well, let's set what fair looks like, right? All agree on the front end, and then let's have these discussions. And so when I say winning and lose, something like the good work isn't happening, but comparatively speaking, we all agree that the outcomes maybe are worse than others, right? And then what do I want it to be is, and then I want to help, right, as a payer, give them the appropriate tools or make sure that there's an ability for them to actually raise the standard, right? And so the idea is, let's raise the bar. And let's use that. And by the way, when we think about the total care being delivered, it's not just about behavioral health, but what is happening in behavioral health that is impacting the total cost of care. And so for my world, and my view is, how do I take money out of the hands of the PCP and bring it into the behavioral health system, right? And so if I could prove out and show that, look, through these practice transformation and through what we're doing, we're actually floating the bill for everybody, let's reset some of the payment methodologies away from other areas, thank you, away from other areas and bring it into behavioral health.
All right, we'll do one more and then we'll toss it over to the audience here. I'm gonna ask you all a kind of a magic wand question. So other than what we've talked about already on stage, which I know we've covered a lot, but what is the brick wall you feel like you keep running at when it comes to this dynamic? And Jonathan, it might be slightly different for you, but what is that brick wall that you're like, this is the one problem I really keep trying to solve? And if you had a magic wand around it, what would that solution actually look like in a more detailed kind of way?
I don't know. I guess, can I give you two answers? You go ahead. I mean, we get pretty excited at Simple Practice around two things. One is making it really easy for health plans, health systems, managed care organizations to work with that long tail of solo, small group mental health professionals. And I think there's just so much to be built in terms of that bridge there and not disrupting that current practice environment because it's working really well and we've got a ton of engaged providers in the market. And then the second piece, and this is sort of on the journey, maybe on the rate side, but time is money. And our practitioners spend way too much time, figuring out, does someone have eligibility or not? Where are they at with their copay? And those are hours, literally hours that could be spent providing care. And oftentimes we hear from our providers, 30-40% of a work week is dealing with more of the admin side of working with a health plan or health system. And so that would increase rates by just freeing up that time and collaborating around that.
So my magic wand would be to remove all those barriers from the back office perspective, right? Like, again, every time that I have to have somebody on my team do a claim sweep or reprocess a set of claims only makes our business model less profitable, not more profitable, right? We want things to transact quickly, easily, without abrasion. No offense to any providers in here. We don't want to be talking to you. You don't want to be talking to us. We just want it to work. We should be providing care, and we should be paying you adequately and effectively and quickly for that care. And the only time we should talk is around maybe adding a scope of work or code or negotiating a contract or a value-based payment amount arrangement, and then everything else should just work. So if I had a magic wand, it would be just to make all that work.
I think for us, removing prior auth has been a magic wand, at least in Rhode Island. It's really made a huge difference to reducing our administrative burden and focusing us on patients and trust. I think that a magic wand, because our virtual PHP program is scaling nationally, would be to build a similar relationship of trust and to focus payers nationally on how intermediate levels of care like PHP and IOP can really reduce total cost of care over time.
Yeah, and I think if I had a magic wand, it would have to do with putting together a provider finder for our members where they were able to find providers that, one, take their plan, two, specialize in what they need them to specialize in instead of every box being checked that, you work with adults, adolescents, like all of that. And then also having that availability right, available there so that our members can go and schedule with providers that we know are good.
I think for me, I think this is going to help providers and payers, right? Consistency across things like data sharing and what you're measuring, right? Each provider in your networks is in all the other networks too, right? So there's a lot of burden of having to do things differently for each payer. So I think if the payers came together and agreed, right, that would change things immensely for providers and payers.
All right. I'm actually not getting any questions on here, but I'm going to ask folks, if you do have questions, to just come up to the mics and we'll switch off between the two. Or just shout them if you can project.
So I'm curious if you think, you talked about the magic wand, if the culture for the provider is as nice and motivating for them, forget the money for just a second, what do you think the culture is like today for young people coming in this space?
I'll repeat the question. The question was, what do we think the culture is today for the young folks coming into this space, if we look at it from that lens?
Oh, that's a really good question. I think that when you are new out of school, you're excited to work with people, right? You go and do your pre-licensure work at, maybe in community mental health or maybe in a practice where you have some supervision. But then we kind of see that, providers tend to leave networks because of all the administrative burden. There's a market out there. Behavioral health is the only discipline where there's a market where you don't have to take insurance. Like there aren't really any doctors. You can't go to a surgeon and be like, I'll just pay you cash. It's just, people don't do it. So I think that people become jaded by a lot of the things they have to deal with when they're participating with an insurer. So that could, make them leave a network or change their practice. I don't know if that fully answers your question, but I think people leave school with a lot of optimism.
Well, I think, right, and there's those anecdotal stories that are getting passed from generations of provider to provider. And I think it's overwhelming, right? There's so many ways to work now with digital companies, and you can be in private practice but work for a larger company. And I think the amount of choices and ways to work are immensely overwhelming. And a lot of the more seasoned clinicians, right, haven't experienced that either. So I'm guessing there's probably a mentorship gap as well in helping people navigate that.
Why don't we start here and then I'll move over that side.
So I'm interested in winners and losers and who decides what the outcomes are and what is high quality. What are those metrics that we're looking at and how flexible are they with different types of clients and patients?
I guess I'll take that one. No. So it really goes back to what is being measured, right? And landing on those things. So is it the GAT7? Is it PHQ-9? Is it something else? Like whatever. And it really is finding it where it sits. There's so many measurement tools and so many opportunities, but where does it sit? And where does it sit? I'm going to say this word again, at scale. And agree to those things well in advance. And then as far as setting a baseline, it's really around improvement versus we want it to be, we want all the 10s to be at 4s or anything above 10 to be at, 5 and when it done in an 8-session model. No, but really understanding if that's, in the aggregate, if the average is 10, let's incent around and put value around going from 10 to 8 to 6 to whatever the numbers are, right? And so it's really about percentage change and automatically, getting down to an appropriate baseline.
Can I do a quick follow-up? So you're talking about in aggregate. So when we're really looking at individual clinicians, there's not really a way for those of us who are in solo practice to actually compete at this level. And so we're being left out. And so do we have an answer on how individual clinicians can actually participate in this new model that seems to be all the rage?
Right, so that's what I was speaking about earlier at scale. So it's an aggregation of that data, right, that then plays into what's happening at the individual level. And then that's where you also risk rate the individual patients that are being seen. So that now where it becomes challenging is to the point that was made around, you could be working with a lot of different payers and maybe even have some private pay. So if you only have, one member that you're seeing of ours, you're probably not going to be able to participate, right? You need to have more than one, right? The N has to be larger than 1. Does it have to be 10? Probably not. But that's where we take a series of solo practitioners that all have, instead of a practice of 1, how do we make that practice of 1 look like a large group? Is it 50 solo practitioners? 100? I don't know what the number is, but how do we make it look broader and say, okay, we'll start maybe with, are you measuring? And then send you there. And then go from there to say, all right, now are we seeing functional improvements in what's happening? Right, so you have to start somewhere. And so that's when I say at scale, it's allowing individual practitioners to participate in a broader system by aggregating those same practitioners. Okay. Not easy, by the way. Much easier said than done.
Nice. Okay, I'm going to ask a similar question that you guys have been tackling on this panel, maybe from a slightly different angle and more practically. I have a very forward-thinking psychiatric group practice, and classically we've been providing care just using office visit codes, right? Like standard, this is what we all do. Payers pay, they know that their patients can have an office visit every 1, 2, or 3 months, depending, life goes on. And then the problem is the psychiatrists are jammed, right? We only have like 600 slots, and that's the end of it for everyone after all that training. In order to break out of that, we've got to start thinking as population docs. It like breaks my heart with the number of people who call for help and 1 month away, or I don't know if we can help you, right? So that means you need to do measurement-based care, you need to have a population health focus, you need to have levels of care management that are not just the physician carrying the cases, you need to have lifestyle, medicine-type components to optimize. I mean, how many depressives have the clinicians in this room healed with just getting them to go to sleep or exercising? You will wake up and go, right? But then the moment you look at practicing like that, you're swimming away from the comfortable frontier of, I'm a doctor, this is my office visit, pay me. And all of a sudden you've got care management, online evaluation codes, you've got health behavior assessment, all different services that are now popping up and may actually raise the ticket price per month on the patient, but also increase the capacity dramatically. For the practice, and probably if we had visibility into the total cost of care for managing that population might actually help. But we don't have visibility into that, and we all have stories of our friend or colleague who get audited and destroyed because we have to manage our cash flow, and a shot to the chest is as easy as a payer calling us up and saying you're in audit and send us all your notes for everything and we're holding payments, and you're dead. And so this fear actually stifles innovation. It prevents us from moving forward. Look at all these beautiful tools in this room, in the expo hall, of all the things we could be doing, and the amount of work it takes to spin them all together to deliver a care experience that we could all be proud of and love, right? So as I decided in 2025, I'm going to start scaling a beautiful model of care, I still have this fear of are these people going to threaten the security of my family as I'm trying to innovate? And maybe that's just fear, but I'm wondering what words of comfort you can provide, and also what are the proper pathways of turning you guys into active partners to help us innovate at this, because we're not going to get out of this mental health problem unless more and more of us create a movement of practicing in these more leveraged ways. And so there's a certain paradox here. I feel like I'm going to be helping the system, but in the meanwhile, it's going to generate more revenue, income, and scale. And like, what does that look like to you guys and how to think about it? I remember that a couple years back, E&M codes went for the level 3 office visit. We could bill level 4 because of the new rules. And I know Anthem was just auditing providers nonstop to harass them to go back to level 3 coding, even though we were all following the rules and the devastation that caused. This is sick, right? Like, so like, yeah, that's where I come from.
Yeah, so the
An
question
honest
around-
question.
Right. Sorry, you're getting,
So
you're getting
Jonathan,
it out.
so
yeah.
Jonathan, what do you think?
I think we should all start with what is working though, and I do really think that we should be reshaping in terms of starting with those providing care, because I think a lot of times the tools that are being built for either enterprise grade healthcare or selling into payors and health systems that have very large budgets compared to a small, budding, innovative psychiatry practice from what I can gather. And so I think what I would start with is, how do you want to practice care, and what are the type of tools that you need, where you're spending, most of your time in terms of creating the bottleneck? Is it, and that you're looking to participate in, maybe, as Manny was even alluding to, a risk-bearing type contract, if that's critical to how you want to practice medicine. And so you asked for a pragmatic answers. I think where do you want to take your practice and your partners take your practice, and where are you spending, wasting time? And I'd start testing and iterating with different tools to enable that.
We know how to do it. The question is having stable payment as we do it.
Stable payment?
Yeah. Like having a payer that's not going to mess with you, that says, hey, you're doing something cool. We have your back and we'll pay correctly.
I would
Right?
suggest talking with the payer.
But how do you find that contact? Because you're a small fry.
In Rhode Island,
and
it's
like,
so easy.
It's so easy if you're big. If you're small, literally you send emails and you call around and you can't find the right person to talk to. And it doesn't seem like anyone actually cares.
Yeah, I don't have an answer for you there, because I'm in a small health plan in a very small state, so
I didn't know
everyone
if there's like
knows
some
how to find me.
secret.
Your local therapist listserv. I
What's
see
that?
those all day long, like on
Yeah.
the local therapist listserv. Who has a contact at? Right. I mean, I'm joking, sort of, but also serious, right? Like,
There's
it's
no good-
hard. I get
There's
it.
no
like,
good answer on it. Okay.
Right. From being on, like, I've been on both sides of this. It's hard. Like,
Yeah.
I wish there was a clear answer, but I agree with Sarah. I think opening the conversation, because once you find the person, they're gonna want to hear about your willingness to innovate.
And
Did
maybe
you
start
search
with the
for
smaller plans
network
in your
manager
area.
on like LinkedIn and start like hunting internally?
Yeah. I would.
Yeah.
We
That
can set up
works.
a coffee with a payer or two while we're here. How about that?
Perfect.
All right.
All right.
So I want to ask a question on kind of along the lines of what both of them are talking about, because I think you talk about winners and losers, and I think if we look at just a fee-for-service based system, then the payers say this is a losing proposition. And I really think an uncalled elephant in the room is that on the other side of the fence, if we move fully to a value-based service where, like you were just talking about, Manny, we keep driving to better and better outcomes, that comes to an end game.
Mm-hmm.
And so what's the incentive for the provider to participate in something like that? And I think that's one of the really big hurdles that's just been in the way of propelling value-based service together. So I'm curious what you guys think about where the balance in the middle sits, because for me personally, I feel like ultimately the answer of where we go, not just in behavioral health, but as a health system in general across our entire country, sits someplace in the middle of the spectrum, because you have to have winners and losers, to your point. And if you go to one end of the spectrum or the other, you're not creating that balance.
Yeah, there's definitely going to be a regression to the mean, right? Which is basically what you're saying. And it happens in anything you do within healthcare, right? You do it for long enough, and then the question is, if you stop doing it, does it change things, right? Or do you build in muscle memory? And so you have to continue to evaluate and reset the baselines and evaluate not what you're measuring, but the opportunity to continue to pay for that value. And then again, really driving through from a total cost of care opportunity and really thinking through those collaborative care type models to drive the real opportunity, especially in behavioral health. I would say that for well too long, behavioral health has been supporting primary care practices by default to the benefit of primary care, right? Be it through risk deals, through capitated models, through any number of things. Not that primary care isn't doing a lot of good work, they are, but if you have someone in your care, how often are you seeing that person, and how often do they see their PCP? And they have, a behavioral health condition and other chronic conditions or comorbidities. And so who's really driving the opportunity on behavior change and engagement? And so part of the aligning incentives is, let's get those incentives in the right place so that that overall value of what we're doing within the health system, right, or the systems of care that we operate in, then there's opportunity for all of us to do better, right? And I think that's part of the holy grail, but that's the hard part. And the big difference with behavioral health that we don't see in other types of systems of care is, like, if you're a solo practitioner, you're a solo practitioner. If you're a primary care physician, you have a front office staff, you may have some nurses underneath you, you have a different volume set and activity, right? You don't have that if you're a sole practitioner. You have like, solo means really literally means one. And so when you talk about these health systems and where the impacts are, behavioral health today is so dispersed, right? It's how do we create opportunities for commonality to drive value? And then you could really do things more meaningful. All right? Because if you expect somebody like our company to go out and contract for value-based payment with 100,000 solo practitioners, like, I can't do that. I can't operationalize it like that.
Yeah.
That's the truth, unfortunately.
We all have to be committed to driving the dollars to the right places, ultimately. Yep. Thank you.
I have a follow-up question, and then we'll come to you. Knowing that you can't contract with 100,000 solo practitioners, how do you change the system, right? Like, no one's making enough money off of a 90836 code to hire a front desk person. That's kind of the reality of it, right? So how do each of you think about the ways you kind of change that system to help move that along?
I mean, we think of it in the sense that we do make it as easy, unfortunately on the cash pay side today to process, over, 6.5, 7 billion of payments in a very seamless, easy way to contract. And credit card processing is very painful, and there's a lot of back-end workflows. And so we have hope that we can make that easy for individual providers on the commercial and the government side.
I would just say really quickly is, like, looking for key channel partners that can help you do it, right? Like, having contracts with 100,000 providers is hard, but it's doable. We have a network of, that's that large of solo practitioners, if not larger. So it's doable over many years. But then the question becomes, how do you move to things that are around value payments at scale? It's working with the right channel partners.
I think it's also thinking about reimbursing for non-typical types of providers to support the clinicians. So community health workers, case managers, people that can work inside of a therapy office to kind of help do some of that non-clinical coordination of care and outreach to keep people in treatment.
I think there might also be a role for health systems as aggregators, like we've partnered on upskilling community providers for autism care. I think maybe there are other ways we can think creatively like that.
And I think not every provider wants a value-based arrangement, right? So work with the willing. That makes your jobs a lot easier.
All right, we'll take this last question. Thank you.
Thank you. It's brief. So prior authorization, a lot of what you've all talked about is very progressive, moving forward, kind of partnership, but help us understand the role of prior authorization and the intensity of the workload it creates for clinicians to, how does that help you advance your business? How does it help you manage care?
So we don't do it anymore, so it didn't.
Okay.
We still do have a utilization management team in the hospital. We're doing concurrent reviews for other payers, and not doing it for Blue Cross has really reduced our administrative burden significantly. So.
We're at time, so I will answer that right after.
All right, you'll have to track him down.
Oh, yeah.
All right. All right. Thank you so much, everybody. We are at time. Really appreciate all the questions. Enjoy the rest of your day.